I want to say thank you to the organizing committee for this opportunity. I am at Ohio State. Uri has to put up with me on a weekly basis. We share a multi-D clinic together. And let's jump right into it. I don't think I have control as of yet. Ah, perfect. So just I'm going to skip through a lot of the introductory stuff because I think it's been covered so well by the entire team. And it's an honor to be the only radiation oncologist here. I really think of spine disorders as a team event. And I think everybody here has said that. And as you can see from this picture, we're all being patient-centric and everybody's involved. And at Ohio State, we have truly a multidisciplinary decision-making process, and all of these folks are involved, including engineering at the Spine Institute, as well as our physics team, who specifically work with our spine patients, which is very relevant and important. This is just a small figure that what everybody knows with better both immunotherapy, so non-specific type treatments, but also specific mutational treatments. Our folks with metastasis are living longer and longer. And so it becomes crucial for us to do a better job for them at the local level. These are all slides that I think the team is well aware of, but it's important to note just from NCCN guidelines that high doses, stereotactic radiosurgery type doses are, even though the insurance companies like to argue with us, are important for radiation-resistant tumors. And I agree with Dr. Bilski in his comment earlier. In essence, if you can deliver a high enough dose, there's no such thing as a radio-resistant tumors. So even chordomas are radiation sensitive, but they have to be the doses north of 70 to 75 gray and 2 gray per fraction, or high stereotactic doses. So I agree with that concept. What I really like, and this is all from the MSK team with Dr. Bilski and Dr. Yamada, I really like this concept of gnomes, because we have to be holistic, and I'll share some of our data a little later. So we're looking at neurologic components and where the disease is in terms of when can we give stereotactic or not. We're looking at oncologic, not only radiosensitive and radiation resistant, but also that burden of disease throughout the body, and we're seeing some interesting outcomes with that even our local control is being affected by something like that. But the regular players are melanoma and non-small cell RCC and sarcomas and so forth. I don't have to talk about the SINS criteria. Dr. Mendel covered that thoroughly. And like we talked about, the systemic disease and the Takahashi score, but also this is the important point of having our medical oncology colleagues there and thinking with our sort of oncologic capital O and small everything else, the idea of seeing the patient as a whole. So just some basics. When we see that little C in front of it, it's conventional external beam radiation therapy. And as you can see here, the radiation is through and through. But the dose can't be that high because we're worried about normal tissue. Whereas in stereotactic radiosurgery, the fractionation is usually 1 to 5 fractions. You can see here, for example, the circumferential treatment, or the affectionately known as a donut treatment, which we soon will publish as one of the larger series. You can see the cord in the middle is being protected. You can see it in the sagittal view as well. SRS has its benefits. You are giving higher biologic dose, shorter duration, and you're giving less dose to the surrounding tissues. And I don't think I have to, and it can be delivered by multiple. There's no data to suggest that one particular delivery is better than the other. You just need to have the technology to do it appropriately. We have a Linac-based VMAT robotic couch. In a couple of years, we're also going to have protons. But folks that have CyberKnife for upper cervical spine, sometimes Gamma Knife can be used as well. These are immobilization devices. I always tell my patients, I need to make you comfortable, and immobile. A moving target is much harder to hit than a still target. And this is for head and neck cases where we have for cervical spine cases where we have head and neck type of immobilizations. And we're looking at what do we need for help. We always need our imaging to help us. We always need a T1 post-contrast and a T2, or in a surgical setting, a myelogram. But now with the new carbon fiber, perhaps those myelograms are not as necessary, and that becomes relevant and important as we speak. So why is this 1 to 2 millimeters so relevant? Well, this figure kind of puts it all together for us. So if you can look, the 100% isodose line is the orange, and the distance between the 100% isodose line and the 40% isodose line is 5 millimeters. So any small shift in more than 2 to 3 millimeters can actually cause an increased dose to the cord and then can potentially harm our patient. So our accuracy with 6 degrees of freedom of our couches and so forth is something that we take very seriously and very crucial for patient safety. Folks have talked about this. There have been consensus guidelines for target delineation, both for the spine, but also the sacrum as well. And we use these routinely, and they're important for folks to be aware of. There's different ways of dealing with things. Folks throughout the country and in North America at the very least will use no margin for their planning target volume. Like us at Ohio State. In Canada, it's anywhere from 1 to 3 millimeters. And so you have those anywhere from 0 to 2 millimeters as well for organs at risk. We're conservative at Ohio State. We put 2 millimeter margin on the spine because of the adage of, first you do no harm and then you do as much good while you respect rule number 1. When we are drawing either off our T2 or off of T2MR or off of our Milo, we're always giving 4 slices above and below. And then the cauda, we're really not giving a PRV there. Our dose and fractionation, it varies. At OSU, we have 27 and 3 predominantly. Sometimes we do 18 or as high as 24 and 1, especially in chordoma situations. In Canada, there's 12 times 2. Other fractionations include 30 gray and 5 fractions and 25 gray and 5. When we have re-SRS, because very often, regardless with time, the chances of failure within the field are still high, we still give another 27 gray and 3 fractions with good safety. As you can see, the task group 101, which is our physics team within the radiation oncology community with a lot of physician input as well. You can see these are our constraints. Constraints for max point dose for one fraction is 14 gray. For 3 fractions, we go up to 22 gray. And how do we do? Well, you can see a lot of literature. It's about 85 to 90% local control at 1 year. Same thing with pain control. Myelopathy is, I quote, less than 1 or 2 percentage points, which is good. And I think we do a good job of being safe. Vertebral body fracture, though, can vary. So for multi-fraction, it's about 8%. For single fraction at 24 gray, it can go upwards of 39%. And so we have to be very mindful of who we're taking care of and so forth. And this is where the discussions about vertebroplasty in a fractured patient in the prophylactic setting is relevant, because if we know we have about a 30 to 40% chance of further fracture, perhaps this is a good time where we can give a vertebroplasty or kyphoplasty and then do stereotactic radiosurgery subsequently. The higher the dose, the more likely to cause a fracture. I always tell my patients, you think about cancer cells in the vertebral body acting like pillars that stabilize a home. Well, if I come in with radiation and I kill the cancer, henceforth kill the pillars, there's a chance that we can fracture there. And so, but the higher the dose, the higher the chance that I'm going to kill something cancer-wise, the more likely that I'm going to destabilize the vertebral body, and that makes sense. Some of our patients will have a pain flare. The numbers of this are not very high. I'd say about 1 out of 10 of my patients will have this, and usually a Medrol dose back is sufficient. We have some preliminary data from 2 studies that are randomized, so phase 3, which is fantastic. One is from the RTOG, which is gave either 16 or 18 gray, so not quite the dose that we're normally akin to, versus external beam radiation, a palliative dose of 8 gray, and it found 2 things really. One was that it can be delivered safely without any harm. However, the pain difference between the conventional and the stereotactic was not different at 1, 3, and 6 months. We have a second by Dr. Segal in Canada. The dosing here is a little bit different, so you can already see 24 gray in 2 fractions versus 20 gray in 5 fractions, which is a typical conventional radiation dose that we use at Ohio State as well. And here, we had really good pain responses in comparison, 35 to 14% at 3 months versus 32 to 16% at 6 months. And so we can see that there are some differences here, and this data is still maturing. So we're waiting for the local control differences, which I think will be the most telling, and the phase 3 data is really appreciated. So in summary, we need to have some sort of a system to work as a team, to think of the patient holistically, and things like NOMS help us, and things like the esteemed faculty that have presented thus far. And so what have we been doing at Ohio State? One of the papers that we just published looked at postoperative stereotactic radiation therapy. And we found 2 things that I think make a lot of sense, especially when we consider separation surgeries. If you wait longer than 40 days for your stereotactic radiosurgery after your surgery, meaning that time frame, then you have about a 20% decrease in local control. Interestingly, if you embolize these patients, and Dr. Mendel will tell you, especially RCCs and thyroid cancers, we see him embolize a lot of these patients. We started to notice about a 12% difference in local control. And when you think about how radiation is killing cancer, it may start to make sense, because at higher doses, it's not so much an oxygen effect as it may be an apoptotic and a sphingomyelin pathway effect. And so there may be some synergism here. And this is interesting and something that we're trying to pursue a prospective trial for. One of the things I mentioned before is utilizing the circumferential treatment, or the quote unquote donut treatment. And we're about to submit this paper where we had about 64 patients, and usually the tumor burden in these folks is higher, but we're still getting close to 85% local control, or 15% local failures. Interestingly, we also saw that if the systemic disease is stable, then the local control was as high as 94%. However, if the systemic disease, if there was progression or so forth, that local control dropped significantly, and there was a 32% difference, which is great to show with data, but I think obviously makes sense clinically as well. And we talked about this, and Dr. Bilski mentioned it as well. The higher your disease burden, so if you had more than 132 cc's that you were being treated for, then your local control was lower than if you had less than 132 cc's treatments. So the disease burden also locally makes a difference. And we always like great cases, and so here's a case where we treated someone circumferentially, and you can see the tumor progressing from left to right. So A and B is pre, C and D is the treatment itself, and then E and F are 4 months after. And you can see how nicely the tumor regressed, and the patient is stable and functional. And toxicity in this group was overall minimal. There was really, most of the toxicity was grade 1, grade 2, fatigue, grade 1, shortness of breath and skin reaction. Vertebral body fracture occurred in 2 who had progression. 16 were pretty stable, and 16 had no vertebral body fracture rates, and 10 were stable. There's no spinal cord myelopathy, thankfully, and there's no higher grade toxicities in this. So what are we doing? And Dr. Mendel mentioned this. I showed this before. Our patients are living, multiple years now with metastatic disease. We're looking at our immunotherapy component because, as you can see from this one preclinical data paper, if you give different doses of radiation, so 8 gray times 3, you can argue 9 times 3 versus 20 gray. In 20 gray times 1, the immune system doesn't seem to be as responsive as you can see here. There's no synergy with anti-CTLA4 and anti-PD1, so your ipi-nivos, whereas here that's what you have. And so we're utilizing that information. We're working with the Spine Research Institute. We have now a prospective protocol where we're taking all of our patients who are getting stereotactic radiosurgery, and if they're getting surgery or not, we're modeling them. We're utilizing our imaging because we've standardized our imaging to include things like, vibe sequencers, perfusion, and so forth. And we're trying to really get an understanding by having prospective data to help us through AI start to better predict who's going to fracture, so that we can get to that personalized medicine. But in order to do that, it really takes a team of a lot of people. So we've initiated this trial where all of our stereotactic patients are on this trial, and prospectively we have over 65 data points clinically, plus another 20 from radiation treatments. And we have tissue opportunities. Only immunotherapy is allowed to be given during the stereotactic treatments, and other chemotherapies are held during the short duration. And we're looking at fracture rate, 12-month local control, and primary time to progression. And obviously, we're going to be looking at abscopal effects and try to do as much translational work as possible. We've started to do a lot of mouse work as well to try to get, we have some interesting tumor models of mice that have tumor infiltrating the vertebral body, which we're going to look at before and after to try to see if we can look at micro CTs and really develop a trabecular bone type of modeling so that we can extrapolate to higher vertebrates. So with that, I want to thank everybody. I appreciate the organizers allowing me to kind of jump the line a little bit here, because these three we're put up a barbecue out there and they're chomping at the bits and they're quite hungry. So with that, I say thank you, and I'm happy to answer any questions that you may have.
Dr. Blakaj. Sorry.
And you can call me Duke. When I got to this country, Duke is a nickname I picked up, and I'm a John Wayne fan, so not a problem.
All right, John Wayne. Duke, thank you. Great talk, super stuff, and I don't want to keep you from your barbecue. It looks delicious. So a common question as we're about to enter the lab with new biomaterials is, as a radiation oncologist, what kind of material do you hate most seeing when your spine surgeons have left the field? So what does titanium mean to you? What does cobalt chromium do you prefer?
So great question. So right now we have three constructs where we're looking at spine constructs with cobalt chromium, with titanium, as well as with carbon fiber. And so we're looking, because we have at Ohio State, we're one of the first places to also have something called flash radiation therapy. This is high dose rate and microsecond delivery of really high doses of radiation. And this is something that is going to be coming in the future. And we're looking at this not just for spine potentially, but anything else, CNS and so forth. So anything that has a high Z material, we're not so excited about. Titanium is something that we're used to because that's what we do the most of. We're hoping to see what carbon fiber is going to bring. That's something that we're actively doing with the neurosurgical team. I don't like seeing any kind of, so cobalt, cobalt chromium, it's there, it's not used as much. I don't like to see connectors right near where we're going to be treating, because that really keeps me from seeing something. And it's hard for me to treat something that I can't see. So I think the answer to this is I'm hoping that carbon fiber doesn't stay as expensive as it is, because and we other folks have talked about this, and I'm excited to see more of the data from Germany. But I think we're looking at and trying to see also not just what photons do, what electrons do, but also what flash radiation therapy will do as we move forward. Hopefully that answered it a little bit.
Yeah, no, I mean, this is had a lot of stuff in there. Just quickly, proton beam and metals. So does proton beam allow for better or worse kind of radiation coverage? I heard a lot of mixed things about that. We have a proton beam accelerator here at UW, and comparing SBRT to proton beam, SBRT seems to be a little bit more metal friendly than proton.
Yes, it's fully correct. And I think what you're bringing, so usually in those scenarios, we're trying to use volumetric arc therapy, but it's photon based. The proton, I mean, the Bragg peak, it becomes a question, because if, so in protons, what we're doing is we're providing radiation and then we're stopping. So we have a fourth dimension, a depth, if you will. If you can't predict that depth, then you can really cause some harm. And if that Bragg peak falls on the cord, now you really harm the patient. And so any metal is really going to distort that, and it makes it potentially unsafe. So there's a lot to learn. That's part of the reason we're doing all this stuff that I mentioned in silico, to try to start to learn more in silicos, because you're not harming anybody before you get there. And so the preclinical stuff is going to be crucial. But I agree with you fully.
Let me go back to the beginning of the lecture, and I promise that's my last question.
Oh.
And that is these kind of team efforts when we have a tumor panel, an oncologic panel. What I've watched, I've seen many of these in many different hospital systems. And what I usually see is that the most enigmatic person, when there's a controversy, wins. So it's not necessarily that clear. We have so many gray zones. And you seem to be a very, very winning person, but then you have Hudi Mendel. So how does this actually work? What is your advice in terms of avoiding the enigma effect and staying with kind of the fact?
We do a lot of arm wrestling. And whoever wins the arm wrestling competition, no, all joking aside, I think the most important thing is to be patient-centric. And so even when Udi and I argue, and I'll let him speak up, we will disagree, and we will disagree publicly. But where we've won each other is we both understand that we're patient-centric. And what we need to do is have a united front, because the moment we present something in a non-united way to our patients, we've lost all credibility. And I think that's something that you and the whole team knows better than I, but that's essentially how we've gone along. Udi's put up with me for the last almost 8 years now. But it's that patient-centric component. And we have an interventional radiologist as well that is as strong-spirited as Udi and I are. So we have three strong folks who we read the data, we're data-driven, we're not feelings-driven, and we're patient-driven. And I think as long as we provide that and understand and be respectful towards each other in a professional way, I think it goes a long way.
Yeah, I think it goes back to this spine tumor board that I mentioned, that for us is very critical, because we do have some disagreements, but they're all healthy disagreements. And I think that, when you're dealing with patients with spine tumors, a lot of things can be done and a lot of things should not be done. And it should be multidisciplinary in nature. This is not, you got a radiculopathy and you did some physical therapy and you do an ACDF. These are critical decisions. And sometimes you don't have time to get into tumor board. And it could be Friday, as you said, Jan, right? The consult's coming in on Friday night, and you got somebody with multiple myeloma and severe cord compression, neurologically intact, but you're worried the cord is severely compromised. And are you going to do surgery? Are you going to radiate? The multidisciplinary component should be continuing regardless of the timing of the tumor board. But the tumor board ultimately yield the team's approach when it comes to patient-centric treatment. And so I think that when it comes to this type of patient population, you cannot work in isolation. You have to work in a team's approach. This is the type of patients that demands it and need it. And so every patient that I deal with, and Duke can tell you that, I make sure that the radiation oncologists are on board or not on board. It's very critical to get their opinion, that you talk directly to the medical oncologist, because there's a lot of things, as you can see, that we can do, but sometimes the question is, should we do it, and are there any other ways to do it differently? So that tumor board, or that multidisciplinary component, I think is very critical in any patients who have spine tumor disease.